Hey Cassie, how's it going? Sorry I'm way late tonight. It's crazy around the house. And then my mom needed a printer cable that I had to go find. So that was fun. But we got company over and they're all happy playing video games. We've got one more to pick up tonight at the airport. Seems like their flight got delayed till 10 o'clock tonight, so it's all right. My oldest will be driving to Vegas to pick them up, so we live about 2 hours outside of Vegas. So we'll have even more over tomorrow. But I think somebody that I mentor is supposed to be taking their test tomorrow. But I may have gotten it mistaken and maybe it's next Saturday. But I was wondering if there was somebody on my live that's going to do their test tomorrow. Yuma, yeah, super. That's really close to the Mexican border. Before COVID, 2 years ago, I used to go down to Yuma to do a drug run every year. Oops, I better not say that on a live, but it's super easy to go down there and just get refills of your blood pressure medicines and stuff, because you can get like hydrochlorothiazide, 100 pills in a bottle for 59 cents. And it's from the same manufacturer. So we cross the border into Mexico and I get my mom's blood pressure meds or diabetes meds. I get antibiotics for my special needs cat, where you can buy them 100 capsules for $5. It's doxycycline. He was on forever. It's a trip for sure, because it's like Yuma is the very bottom of Arizona, and I'm at the very, very tippy top of Arizona. So it's like a 6-hour drive, but you drive there, drive back, and you just cross over and go to the pharmacy there. And with no prescriptions, you can just get enough. I used to get albuterol for my kids, by the box full, by the load full. Very useful, very useful. Need to go back. Starting to get a little low on meds. Albuterol and stuff has just become way too expensive. Like, these are the albuterol inhalers, and I can get 3 of them for $12 in Mexico, and it's just albuterol inhaler. It's cheaper than using my health insurance and doing a copay, for sure, because albuterol through my insurance with a coupon from Walgreens is $45. But yeah, these are really cool. And you don't need to have Mexican money. You can just take your debit card, whatever, or cash. And like, these are the doxycycline that I get 100 pills per bottle. And if I go to the pharmacy, and I actually go to the pharmacy here in the United States, they give me 30 of them. I have to get them refilled every month, and it's another $45. But if I go to Mexico, I can get 100 of these for like $25, and it's the same green and white lovely little pill. There ain't no difference in them. They're made by the same manufacturer. And anything else, erythromycin, you can get 100 pills per bottle, $25 to $30 for 100 pills. That's why a lot of people that live north up near Canada go and cross the border and buy just from the pharmacies direct there. But if you're on routine maintenance meds, or your pets are, and he's a cat. I don't know why it says a dog, but it's a lot, and the American healthcare system charges way too much money for this kind of stuff. But love Yuma for sure. You can get everything down there, even those pills from like birth control pills. You can get ovulation pills if you're trying to get pregnant. Oh God. You can get everything under the sun except for probably like Soma. They really don't want you crossing the border with that. A sulfur antibiotic. But you can get the mixture antibiotic that's the sulfur and the penicillin. It's a combo drug. You can carry that across. Z-Pack antibiotics, you can carry those across. But you can get anything you want. Diet pills, you name it, you can get it. They'll find it for you. If that pharmacy doesn't have it, they'll call somebody or text them on a cell phone, and within 5 minutes somebody's coming with a black bag with it from another pharmacy. So they're super accommodating. I even had a family member with me that passed out one time, had a drop in blood pressure, and ended up needing to get their heart nerves ablaze because they had too many heartbeats, like it was beating out of time due to electrical interference. We didn't know it at the time, but we were standing there in the pharmacy and they passed plumb out on the floor, and they had a nurse there with waking up snappy thing to wake them up underneath the nose. And I mean, she had a little fanny pack on with all kinds of ready-made stuff, and she wasn't part of the pharmacy but just part of the city, just come running and took care of them, got them awake, and gave us juice, and were ready to put us in a hospital. Like, no, we'll take them across the border, but that's okay. We didn't know it was actual heart condition at that time, just figured it was just standing up too quick in the heat. But anyway, they're super nice, super friendly, and just not a lot of bathrooms. There's a casino in Yuma. We always stop at, use the bathroom there, and do the ATM there, and then park in the parking lot at the casino, and then walk across the border and then come right back. So that's it. Super nice. You can get your glasses done while you're there. So if you have a prescription for your glasses, and y'all know, even with prescription glasses, if you get it done, they charge you like $200 for that. The scratch resistance, the lens transitions, the frames, and all that stuff, they charge a lot of money here in the United States, even with the insurance. But if you just take your prescription in and drop it off at the lab and pick out your frames, you can walk out of Mexico with everything that you would pay $250 for $40, and you can negotiate too. You can say, no, that's just too much, and start to walk out, and you get a better deal the farther you walk away from the store too. So, whatever you want to pay, you can get those. I'm sure they're counterfeit microcores purses and stuff, but they all look the same. I don't know, but I don't carry a purse. I put my debit cards in my phone, and I have chapstick in my pocket, and I don't ever carry a purse, even here in the United States. I'm not a purse carrier, but a lot of people are. They always have that kind of stuff there. It's a pretty day, and if you go in October during the Day of the Dead festival, it is super fun because everybody's drunk, and they're all got pretty makeup on, and the kids are out dancing, and we've got extra vendors out. It's really fun to go in October. if you live anywhere near Yuma. It's really fun. Let's see. All right, let me see. What have I got going on? My boot camp instructor had a gastric ban in Mexico because, yeah, it is. And I see a lot of people. There's a lady I follow on TikTok, Vegas Starfish or something like that. She's always showing people around Vegas and where to go and what to do. She just had her gastric ban, and she lost 100 pounds like in 8 months. And then she went back and just had a mini facelift, but they turned it into a major facelift when she got there, and she was a little wish she probably hadn't have done that. The mini would have been just fine, but she goes to Mexico all the time to get all those done. She took her stitches out too soon from behind her ears, and she had some separation from her face, scooted back down some because she took her stitches out too soon. So you got to be careful because you don't have a lot of aftercare with some of those things. So you kind of left on your own to figure out when to do things, and that's okay. They do a really wonderful job, and they are super friendly, super worried whether a bad word will be said about them, and they go based on referrals always. So just getting us go down there during COVID has been a challenge. So they work really hard to make sure nobody dies, everybody survives. They do CT scans of everybody's chest now just to do the gastrosurgery, whether they just put a sleeve over it or you actually have part of your stomach removed. They'll do a CT of your chest, EKGs, and blood work just to make sure you've never had COVID or don't have any lung damage from anything else before they put you under anesthesia. Even our doctors here in the United States won't do no CT or an MRI of your chest before they do a surgery. They could care less whether you're going to die on the table or not, and they're going to charge you $25,000 for it. I hear a lot of people go in for their dental work down there too, so it seems pretty cool. It was like staying at a 5-star resort. It is. They really use every dollar to make sure that people are well taken care of down there. It's still scary, but oh my gosh, my kids are getting beat by their uncle. Uncle Chris, he's like 30 years old now. Yeah, so they're in there just playing. Oh my gosh, they're so loud. Let's see. Hey, coupon cutie. I'm still ashamed I bought toothpaste this week. Yes, sure did. All right. So what does everybody want to go over today on coding and getting their certification? I know modifiers were one of the ones that people were talking about. They wanted to go over. I have this cheat sheet that I love, and I put it at the end of the E&M section of the CPT book because you've got a whole page just for notes, and I could write it out big and change the colors, and then I know what the differences are. Professional component on 26. So you only use it if the professional component is not already included in this test. So let's say there's a lot of tests out there where professional component you would add the modifier 26 to. And those are mostly like if a patient goes to see a cardiologist and the cardiologist does the stress test in his office, his primary office. It's in a building where he sees every single patient. It's not an outpatient surgery center, but he can actually do the stress test there in his office. He runs them, he puts them on a bike, and he injects the injectable medication to make their heart beat fast. He produces the results. He reads the results in his office and gives the primary care physician a report. Then he can add the 26 modifier to that particular one because usually stuff like that is done in an outpatient center. And if it's done at the outpatient center, or a hospital, they don't get the professional component because they didn't buy the machine, put it in their office, and that kind of stuff. The hospital gets their little rate of whatever that code is, and there's no professional component added to it. So a lot of times your parenthetical notes will say whether they can use professional component or not. A lot of that is going to end up being in radiology as far as anything that's going to require a professional component. There are going to be some ones in lab and path also that could get it. And under lab and path, it will be the ones where the doctor is actually removing the piece of skin. Then he is also, or she is putting the piece of skin under the slide and telling the patient and writing a report during the surgery that it is cancer or not, what type of cell. So you will see the words interpretation given in the test question when you can use the modifier 26 usually. Some CPT codes include interpretation. You just need to read your guidelines right before the set of codes, and it'll tell you if it includes interpretation or not. If it doesn't say anything, then you're okay to use it. Also, check your parenthetical notes afterwards. It'll say doesn't qualify for 26 or something like that. That's as best of a clue as I got. Also, you need to network with other people who have used those CPTs before and know whether they can use a professional component before, whether they've taken the exam before and had that question and got it wrong or right. Also, people that have actually billed for that code and gotten back an EOB, an explanation of benefits, and it was either denied or approved from the health plans. That too will also give you the information, but still you need to network with people that tell you. And anytime that I find information that says you can't use a certain modifier, that it's not noted in this book, of course I write it in my notes to say that. And I do have quite a few that say it. Like these, you can't use modifier 51. There's other ones that you can't use too in certain situations. And if I find out which ones you can use and can't use, then I put that information here. This particular example up here where they were removing and asking for a path report, and this path report was examining a part of ischemia from the right leg, and then they also had some arterial plaque that needed to be done from a femoral artery, and another one was from a cutaneous ulcer. This one did get a professional component because in the test question it also wanted them to go over and give an interpretation report of it. They didn't put it, in some machine or something. The doctor put it under a slide and looked at it. A lot of these from the 88300 to the 88309 will probably end up having a professional component code that you can add to those because the doctor's actually doing an examination and visually looking under a microscope or something for the results and giving you a report on it. Other ones I've had in the same area. This one was a level 4, and it was H. pylori 1. This one had it had six different slides that the doctor looked at, But for some reason or another, none of them had the professional component with it. I'm not certain, unless I know the example for sure, what makes a difference. I believe the skin and knowing what type of skin disturbance is going on for legs, ulcers, arteries, do get the professional component. But when you're talking about stains, just to stain a particular slide or a piece of skin and give you a result does not require the professional component. I guess because the stain is doing all the work. The doctor isn't having to do anything to it because the stain just gives you the color and you know what it is and you just state what it is. With the other things, you actually have to analyze the cells under the microscope and come up with a determination with your head. You know, what does that look like? With the stains, it seems to be, it's the only thing I can think of in auditing that you just stain it and you report the color. There's no thought process in that. Anyone could do that. I hope that helps a little bit. Moz, yes, I love Moz. What if the physician does the x-ray in his office? That's also a professional component, yes. If you send a patient to an outpatient service center to get an x-ray, you do not get the professional component. But if they have an x-ray machine in their office, they get extra kudo points, money for that, and they do get the professional component. Yep, Moz. Love the Moz. I used to refuse to learn them forever. I didn't want to know them. Didn't want to even pretend to know them. And because they have their own set of guidelines that is separate from all the other guidelines in integumentary. So I just refuse to learn it. There's certain things that you're going to find in these books that you just can't learn. There's so much information. When you're starting out, you need to get your core basics and let that simmer and really learn those for quite a while. 6 months, 9 months, before you start worrying about the specialty things that are in this book, like Moz. Once you learn your core basics, you're going to be able to have you're going to just have more file space in your brain to be able to comprehend what's going on some of these things, I believe. I don't think you can take on every single guideline, every single procedure, and learn all of this before your exam. There's going to be some things you're just not going to know how to do. Now, I can teach you enough about Moz to get you to pass the one question. There's only going to be one about Moz. There might be two, but there's going to be one question. And they're all weighted the same. You have 150 questions, whether they're long super notes or it's one anatomy definition. They're all weighted the same no matter what. So don't spend too much time on any question. You really need to practice getting through those questions within 2 minutes each, and that's 120 seconds from the time you just gaze at the answer. So the timer ticks before you even get to a code. You can't look up every code in the answer either. You understand, Moz? Moz are pretty cool. I'll just go over them real quick. They're divided into two groups. Let me see if I can't get this bigger. Here we go. I hate my little crane. Okay, good. Two groups. And first, you're going to do Moz by locations. I have a little note down here. Number 1, location. So either it's going to be hands, feet, genitalia, something along those lines, or you're going to have the other location. Where is that? The trunk, arms, legs. So face or extremities, basically. Then stages. Number of stages. Stage means how many times did the provider go into the body and cut something off. Did he do it once or twice? That'll give you the stages. 1 cut is here. If he broke it up into something more than 5 blocks, then you add this. Same thing with this. If it was a face, he went one time, cut it up more than 5 blocks, you'll code this one with that one. If he went back into the body twice and cut out something else, you'll code this one for the first stage, this one for the second stage, going back and cutting out a second thing, and then you'll also do whether it's 5 blocks or not, and if it's more than 5, you'll add that. That's the bare basics for those. First it's location, then it's the number of stages, and then how many blocks. A stage equals a slice, a block equals pieces of slice. It's very confusing. It's probably making your head spin if you don't know anything about it, but it's okay. Just look at the location first, and then if they went back in the second stage or they returned to the body and cut something else off after the first one, then you know you're going to do the add-on code underneath at the same area. Okay. If they do 2 different areas, one face and one leg, then you've got both of those, and then just count your blocks. If there's more than 5, you do your add-on code. Super easy. All right. Excuse me, sneezing. Hello, New York. I've seen you a couple of times. Good to see you. Let me know if there's anything y'all want to go over. Be sure you know how to do an integumentary, multiple things at once. What if they have a punch biopsy, skin tag removal, and a lesion removal, all in the same day, same patient? Which one do you code first? Which one's going to be in the sequence first? What if they had 50 skin tags, they did a shave biopsy, and then they had a lesion? Hey, Connor. So you need to make sure you know how to do multiple things and what would be going first. I have an example here for a basal cell carcinoma of the shoulder, 1 centimeter. I had 5 skin tags that went along with it. So you're going to code, of course, your lesion and your cancer removal first, and then your skin tags afterwards. The biggest procedure will always go first. You could have 50 skin tags, but the procedure is just pinching it and slicing it off. It's super easy. They might even put a little chemical on it to make it stop bleeding if you end up with a bleeder. But a lot of times it's just pinch it with tweezers and cut it right off. Or use scissors and cut them off. They come off really easily. Lesions, cancer, skin tags, cyst, boils, whatever it is. Those things, if you're cutting into the body to remove it, and some things you just have to pack the wound. You don't cut into it, you just pop it, squeeze all the stuff out, and then you pack the wound. Whatever the procedure is and how detailed it is or invasive it is, that one's going to go first. Just like with your twin babies. If you have one vaginal, one C-section, the vaginal was born first. The C-section baby was born second. You're always going to build the C-section baby first in the sequence of that OB delivery because that was the most invasive procedure you did on the patient that day. Not on the baby, but on the patient. So C-section will go first, then the vaginal delivery. Same thing with the skins. The biggest thing you're going to do to the body to cut into it, and you may have to do layer sutures. Those are all intermediate and need to be coded first before you do the 100 skin tags. Be sure you know your E&M visits for your eye professionals, your occupational therapy, your physical therapy, your, from putting on getting your glasses adjusted at your eye doctor, and physical therapy reevals, And evaluations, those basically, that's what they are. They're E&M codes. They're going to be back here in medicine. And they're going to be in like the 98 range. So be sure you know where those are. You probably end up having some of those. We've got some chemotherapy back here too that could be important for the chemotherapy administration codes. We already know that the diagnosis code for this is going to be the Z51, but your chemotherapy office visit sort of CPT code is going to be back here too. Your eyeglasses, like I said, your physical therapy, your occupational therapy, group therapy for psychology, single psychology, office visits are going to be back here. Your EEGs, you're going to have some cardiac procedures back here, nerve conjunction studies, even CPR is back here, under medicine. So, unless it's neonatal CPR, which is in the E&M all the way in the front of the book. All the other CPRs for all other reasons besides brand new newborn are back here. Your EKGs are back here. There's a lot of stuff back here that it's weird because you wouldn't think it's a medicine. It's office visits with your psychologist. Why is that back here? But it is. I wish they would put anything that is office related or evaluation and management, like physical therapy or occupational therapy, up in the front of the book. But they put it way back here. Your G-tubes sometimes are back here. Other tests are back here that are really random, ECGs. Here's the evaluation and management for therapeutic services, right near the cochlear implant. So if they get an implant in their ear and then they come in to get their audio adjusted, their E&M visit for that visit is back here. See, all this established patient, new patient. These are for their eyeglasses. Am I in there yet? Yep, ophthalmology, eyeglasses. They're back here. It's like a hodgepodge of stuff. You might want to go through here and just really look at stuff. Your dialysis is right before this. That makes sense because it's medicine, but all kinds of psychotherapy, evaluation, and management stuff is back here. Here's some more psychotherapy. And then your vaccines. That makes sense. That's back here. And flu shots. Some of these are seasonal flu shots, like this section is for the swine flu or the H1N1 when that went around, maybe 10 years ago. And then now our current influenza vaccines are more over here. We've got pages and pages of influenza vaccines, but some of them are really not relevant anymore. I wish they would just take them out of there. But some viruses keep coming up, and we need to keep those specialty, because swine flu could come back again. I had H1N1 because I went on a trip in October and flew during that season to visit my first adopted son, Travis. I've had him since he was 4 months old, but I had to travel to another state to visit him and do some paperwork in October, and I caught it on the airplane going there or coming back, one of the two, for a weekend. And let me tell you, I was sick as a dog, very, very sick, and I had to come back home to my oldest child, going to band camp and drive him there and drive him back, and I was just in the bed. I was done for. That one was not fun. But I still don't get my flu shot every year, so. But I work from mostly home now since then, so I don't travel very far anymore. But I did get the COVID vaccines, and had no reaction to those at all. So that was super, super cool and easy. Even had the boys get theirs. Travis is now 12 years old, so they had theirs and they're fine. No big deal. Just need to know how to code it if you were billing it. We got ours free from CVS. I still can't get my oldest to go get his. He's 29 and he didn't get his, but that's all right. On the eyes, you might need to know which muscle controls the horizontal movement of the eye and which muscle controls the vertical. So for anatomy, that could be important. That was pretty hard to find because it wasn't with the muscles. It's on the other page, and down here, which one controls the horizontal movement. I just wished all this was on one page instead of having to turn it. I just like it on another page. A lot of things are 90-day global, and it's included. And don't let them confuse you on casting supplies. A lot of times it's included in the surgery for whatever ortho thing is going on. The casting supplies are included. Okay, let me check messages real quick. All right. If a report doesn't specify a procedure done, how do you know where to look in the CPT book? I need more of an example than that. Are you saying the approach? You don't know which approach? If I can tell you that if you have a new patient or an established patient, you have no idea, the doctor didn't say, and you don't have any history to tell you, and all the note says is patient was seen today for a well child check and these shots were given. You're not going to code them as a new patient. You will always code them as an established patient. So you always code down, no matter what it is. So maybe if the procedure is manipulation of a fracture into a certain joint to realign it, whichever CPT code is the lowest code for that procedure numerically. Oh my God, the kids are so loud. I don't know if y'all can hear them. Here's some fractures and dislocations. So if they did a fracture repair and they did not tell you if it was without or with manipulation, but you know the body part was this, or the fracture was this one, the fibular fracture, and that's all you have, is that today we saw so-and-so and we fixed their fibular fracture, and you have no other information, you're definitely going to code the very first code in the numerical sequence, because most of these go up in price or up in procedure that they do, because this is all of this. And then when you get here, this code means they did all of this and they did all of this. So if you have nothing, but they fix this fracture, it's going to be that code. You may end up getting queried or something, but as far as a test is concerned, if you don't know the CPC exam or something like that, and they don't tell you, always down code it to the very lowest code possible for that particular procedure. Let me check messages and see. How do you know if a procedure is global for 90 days or not? Usually they tell you. Again, if it doesn't, you need to network with people who's used that code before. You need to, if you find out one is global, then write it down beside the code. You saw one of mine. I had written it down beside the code that said it was a 90-day one. If you answer a question on an practice exam and you get it right or wrong, whatever the result is for that CPT code, write it in. It was 90 days or it was 10 days. Most ortho stuff is 90 days. You've got 6 weeks for OB. You've got 10 days on some sutures or smaller things. It just depends. You got 30 days sometimes on eyes and lenses, but unless you've used the code, and also it will tell you in the notes right before you code the section if they're going to have any information on whether the code is global for however many days. Sometimes they're not consistent in telling you that information. But if it was going to be anywhere, it would be right here in the middle of all this stuff right before each code set in any of the tips. But unfortunately, it's not always there, and you just have to learn the codes and get down to nitty-gritty, knowing everything as you work in them. But all this information right here, if there was a global information for this set of codes right down here, it would tell you in that particular section right there before it. All right, I got an iMessage. Let me see. I never look in the index. I just look at the codes if you're referring to the text. Yeah. You'll never have time to look in the index for anything during the exam anyway, so you need to have everything that you need to know right there. Usually global right here. It's usually included for all those casting supplies. How do you know? How do you code for a new or established patient? It says an office visit. Yep, that's exactly what I was talking about, Michelle. If they say patient was here for an office visit for a sinus infection, you will code the lowest established patient for that. That's it. You will do a 99213. If it specifically says in the E&M guidelines, if it does not state it is a new patient, anywhere that you can find on the note or in a question for the APC CPC exam, then you will code them as an established patient. If it says new patient, you code new patient. If it doesn't say, it's always going to be established. If it says they are returning, that is a hint. It's a very good, Cassie. That's awesome. And if the patient has not been seen in the office for greater than 3 years, yep, they could be considered new patient. But the question or the statement in the question will absolutely say patient hasn't been seen for 3 years. They were overseas. They're new, or new if they're greater than 3 years, for sure. Most of the modifiers you'll use for E&M will be the one for 25, by the way. I know we went over 26 for professional component, but that'll be a rare one question thing for the exam. In the real world, after you test, do you really reference the index? Is there a site you look at? No. Real world, every health plan will want you to bill differently. Every contract a medical group has with a hospital, a lab, or a health plan will code differently. What I recommend doing is if you have a patient who was seen for something weird, like a circumcision in the PCP's office and you don't know how to bill it, go look it up. Search your E&M for that particular procedure code and see how they billed it before you. You'll have policies and procedures, hopefully written in place, where you can go look in your computer system at work, or they might have paper books for that, but that would be archaic. But places that you can look to see how they billed it before. You're not going to be inventing a wheel, and I've never even seen billers bring out a book on their desk. They have a computer program on their computer. If they wanted to look up a diagnosis code that they haven't seen before, they'll just type in some words and the computer program will bring up some options for them. I don't even see them even buying books in doctors' offices. So all this stuff is useless that they teach you in coding books, coding classes. It doesn't help you pass the CPC exam, and it doesn't help you in real life either. You need to get real computer savvy. Don't be afraid to click buttons on an EHR, search for things that have already been billed ahead of time to make yourself look really cool. Like you never have to ask a question. You just go search for it on your own. Go find old patient charts that have already had it done. Super easy to look up and run a query in EHRs based off a CPT code or an ICD10 code. And you can view how other people did it, and you can actually see if it got denied or was approved by the health plan. So you just need to learn a totally different thing once you get on the job. So don't worry, it's all on the job training, but you can make yourself look really smart by just searching it yourself. Google search everything and anything. How do I bill for this? Google will tell you. Yeah, yeah. Do you have all of the modifiers for each section that we will not use? Do you have all of the modifiers for each section? I do to the best of my ability in my notes, yes. Ones that I figure out we cannot use per section, I absolutely put that in, and I also put in the most common ones we will. Anesthesia, you really need to go to the HCPCS book and move those here to your anesthesia ones because there's quite a few. And then for like every section, I put in most common or notes about certain modifiers in the beginning pages right before each ones that are most common will be used. And then again, if it's not going to be used, it's in my notes. The link to those is in the bio. I don't think you can click on that until you're out of my live, but I do have a link in bio that will send you to, if you want a copy of everything that I have written. I'm working on 2022 books right now, and I'm going to make it to where they're not handwritten like this year's was, because some people can't read my handwriting, and I don't blame them. But yes, before every section, which modifiers you will use and which modifiers you don't use. I'm not an expert in coding. I don't like coding. I'm not a coder. I'm an auditor, and I only learned how to code so that I could show you guys how to do it, and just to help y'all out, because I was tired of seeing so many people failing this test. And I only got my CPC to shut people up, because when I go to audits or medical conferences, and I explain who I am and what I do, they're always like, well, what, huh? You do what? Are you a CPC? Is it like they break it down? I'm like, no. And then I have to explain what I do. So I just got it just to shut people up, and so I don't have to have a lengthy conversation about who I am and what I do. But I love auditing. I'm a HEDIS auditor and a CHAPS auditor. I do health plan audits for medical groups, and I do government audits for home health agencies. Those are my favorites. I would love to be able to audit the health plans. That's the only thing I haven't done yet, because I've done all the doctor's offices, the labs, the pharmacies. I've done medical groups, hospitals, but I haven't audited the health plan side, and I would love to audit them one of these days. So that's an area I'm interested in to learn something new in. But I personally ran several clinics and medical groups and labs. I was in charge of everything from payroll to ordering supplies and hiring physicians, training them, and all the staff. I've done it all in medicine, and I've been audited by health plans or government agencies before with my groups that I ran, and just loved it. Just loved all that stuff, and I liked having information ahead of time and proving I knew how to do all the steps, so that was cool. So I've ended up in administration and help medical groups who can't pass or need to pass certain performance audits, and just love it. Just love it. But I really just got my CPC just just to quiet people down during the exam. All of my auditing work is based off volunteering for new projects because I started out in peds. I shot x-rays. I've done OB and delivery. And every time there was an administrative project that nobody wanted to do, I just volunteered for it and figured it out how to do it with Google or reading a manual. So I became pretty versed in all the new lingo coming out for all kinds of audit programs and just worked my way up. 20 years in medicine doing whatever I was doing. I never went to school for that kind of thing. I do have an associate's degree in science, and shot x-rays, did OB and lab and did everything under the sun. But as far as a formal degree in auditing, I do not have. Although I met somebody who used to come and audit my medical group who has a PhD in auditing, and I would love to have that one of these days. So I'm working towards turning the AA into a master's and then turning it into a PhD in auditing. That would be so cool because it's scary too when you walk into a room and they say Dr. So-and-so is an auditor. If you have a PhD in auditing, it's pretty impressive and you're scary to folks, and I'm pretty scary as it is, but that would be awesome just to say. Anyway, it's one of those days. Yay, you go girl. HEDIS is easy. HEDIS is lovely. It's just CPT codes. It's making sure patients are getting their PAPs, mammograms, colonoscopies done. That's all it is a CPT code. And you want to gather that information and you want to get it to the health plans, because if patients are not getting their screenings, then medical stuff kind of builds up and eventually they'll be in the doctor's office super sick. So if you start early and do all the preventative meds, then usually you can stop things at a polyp before it turns into something like stage 5 colon cancer. So if you can remove some polyps ahead of time, that's great. And plus, if you get all of your population in to get all their screenings, then you might get a bonus check from the health plans come March every year for the previous year that ended in December. And health plans are really moving towards that. It's coming from the UK. Everything we do in medicine comes from Canada, if you didn't know. CPT codes, ICD-9, ICD-10, it all came from Canada. Canada's already been on ICD-11 for 10 years. They vet everything. We inherited it because they've already invented it all, and then we try it out here decades later. But that's where all these HEDIS and pay for performance and other guidelines came from. It came from a universal healthcare system from other countries. And, you know, people freak out about universal healthcare. Well, buddy, even how we bill came from a universal healthcare system. So people just have no clue about what they're chattering about online. Anyway, all of it's going to go towards that. We've already got our billing and our guidelines as far as getting referrals and whether a patient can have a certain procedure done or not. It's all based on diagnosis and CPT code related information, and that information also turns into HEDIS information, and you can get paid $50 an hour as an established person who's been in the business doing HEDIS for 3 to 4 years. You can really bump your pay up. Starting, it could be from 30 to 35 an hour just doing HEDIS guidelines, and all it is a scavenger hunt. You try to go find patients who have not had their particular pap or mammogram. If one eye doctor is not doing all of his diabetic eye treatments, then there's a reason. He's either billing the wrong CPT code or he's got the wrong diagnosis code. And I've gone into offices and they're using codes from back in 2008 from an old book somewhere, and their biller has been there for 25 years and doesn't do any updates. So you just go in and say, hey, this is the new code you need to be billing. And then they suddenly start getting reimbursements and checks for whatever they're doing. A lot of these HEDIS things are just finding out what's going on in the office. Sometimes the front desk girl will say, what's your name? And the person will say, my name is Izzy or whatever. And they just type it in just like that instead of looking at the insurance card where it says Elizabeth or John is a James, but they call him Jim. Oh my God, that drives me nuts. Or the wife is using her husband's TRICARE insurance to get preventative at the military base because it's cheaper than using her HMO and paying the copay for crap. So you got to transfer her TRICARE stuff done by her husband's insurance to her HMO plan, not by billing it, but by putting it into their EHR that all the health plans have on every one of their patients. And then they get credit for that particular HEDIS measure. Anyway, it's just a scavenger hunt. It's not that big of a deal. And it does use CPT codes and ICD10 codes. And it's, I think, a funner area than coding is. Billing and coding. Billing and coding is bean counting, I think. It just sounds unbearably boring, but I could be totally wrong. I've never done that job, so I've always done auditing. And I like to be useful and helpful and correct things. So that's just me. So that's cool. That's awesome, Cassie. I hope you get the job for sure. Let me know if you need help with any of the resume or even getting started with a job like that. I am so well versed in HEDIS. I've won the California Passenger Award twice. I beat out every medical group in California. It's a big state. And like Kaiser Permanente, where they have teams of people, whole floors of people being auditors, I've beat them out twice, multiple years to win that award. And I'm just one person working for a medical group. So I love HEDIS. It's fun. It's a competition. I'm always like, I can beat them. I can beat Kaiser. I know I can. I know I can. So that's fun. I even won a Medicare HEDIS award. It's called STARS, is what they call Medicare HEDIS. It's STARS. STARS is the HEDIS measures for Medicare patients, and it's the same thing. But I've won the Medicare award too for that, so it's pretty fun. Hello, Amber. But there's a lot more areas. You just need your CPC to get your foot in the door, and then you can go on to do all kinds of things with the medical groups. Don't forget to look at Glassdoor when you're fixing to interview for a company. Go to Glassdoor and then search for the company you're fixing to interview for, and then search that company for their questions. They have a list of all of the questions that each one of the job opportunities, businesses, or whatever are currently asking their interviewees. So some of them can get quite involved, like United Healthcare will ask you things about when in a position have you felt, most productive, or what project have you done that really made a difference in your position that you have currently. There's things that they ask you that are like, I have a heartbeat and a pulse, and I know this stuff, and I went to school for it. Why don't we just give me a shot and let me go for it? Why do I have to think about all this theoretical stuff? But it's just can come up really fast. And if you do, like with United Healthcare, sometimes they make you do an online interview without a person there. So what will happen is you will log on and you will be on camera, and before they turn on the camera, they'll say, okay, we're going to give you 60 seconds to answer the next question that pops up on the screen. You will only have 60 seconds. The camera will turn off in 60 seconds. And then here's your question. 1, 2, 3. They pop it up on the screen, and you have 60 seconds to answer it right then and there. And then the camera shuts off. And then they'll go to the next question. You'll have 10 questions. They can be quite challenging to do, and they want to check your reflexes and brain acuity and vocabulary. So if you're interviewing with a health plan, which is the route I would wish everybody to go, because you can get a lot of remote positions or local positions where you just go by each one of your physician's offices local in your own town. If you're doing HEDIS audits, look for records and then dash out and go home. Or you can do it remotely through the computer at home and look through their systems and then add the information into the health plans, which is great and lovely. I love those jobs. Those are great entry-level, easy jobs to do. But the interview process can be quite challenging, and it shouldn't be that bad. That's ridiculous. But if you go to Glassdoor and look up the questions ahead of time, you'll have you can write them out, what your response would be, and practice them over and over again in front of the camera, and get you about 45 seconds of data that you know repetitively that you can say without reading. And you can interview really well in that type of situation if you practice. I know it sounds funny, but that's good, helpful information. And I hope you do well, Cassie. What else do y'all want to know about on the CPC exam? In my notes, which I have in the link in bio, I have a list of every code that was on my exam. They're highlighted in pink, and anybody I've mentored who they've come back and told me this code was on my exam or this vocabulary was on my exam, I pink highlight those. And then at the beginning of each section, I write in all the vocabulary that they come back and tell me that they've had. Anything else y'all want to go over? Where's my other phone? Where is it? Where is it? Where is it? There it is. I don't know if you have Android or Apple product, but I'm still an Android girl. But I'm sure Apple has something. I go into that program right here. It's called Lens. So I'll take a picture of a particular thing. If I can get the camera, get it to work. So that picture is in my book. I'll take a picture of it and then have Google search for it. Down here, I'll get some list of stuff. I'm getting all penises. Why am I doing that? It's probably because I was zoomed in too close. Everything looks like that when you zoom in too close. That's so funny. And then I'll search images and I get the thing to come up. That's what that procedure is. And then I'll find more information about what's going on with that procedure. They have some stuff written here, but if I wanted to write some additional information about that particular test, I might find better information on some of these pictures. That's where I find how to draw in some extra vocabulary and add to all the pictures in this book need to be done that way. So hopefully that's helpful. There's probably tons of apps that do picture searches of everything, but you know, these colonoscopies, be sure you know the difference between the MEDICARE code and because you're going to be in the HCPCS code if a patient has a Medicare code. A Medicare patient has a colonoscopy, you're going to get the G code out of the HCPCS book to bill for that. If it's not stated what insurance it is, then you can assume it's just a commercial plan, which will get the one in the CPT book. You know you're going to get some circumcisions. Absolutely. Usually it's a repeat circumcision and an older person getting one for reasons. So be sure you know the difference with a clip, without a clip. Always used on the CPC exam for sure. I see, Miss. That's my TY is in here. She came over from that AAPC instructor, had asked me to be a volunteer instructor and teach 2 classes or 2 sessions with her class. So let me know if you have any questions or want me to go over anything in particular. Your teacher at AAPC has asked me to even teach one of her courses or something for her. So she's gathering up some more information or something for me. So maybe I'll even teach one of her classes next year or next semester or whatever. We'll see. But let me know if you want to know anything. Some things, the radiology part from the radiology section is already included in the procedure. Again, you need to read your notes ahead of time to see if it's included. If they let you know, sometimes they don't let you know. Or network with people who've already taken the test and found out, or just learn it by billing it and getting denials or whatever. Can you go over the Medicare thing? Yep. If it says Medicare, what do we do? Yep. Let me go get another book real quick. My hit picks. So the main things for the CPC exam, if the actual test question says Medicare patient, then you know you're going to this book right here. Be sure you know the actual names for each one of these, because that was a question. 2, be sure you know the actual meaning of this, just FYI. And then on page 7, if you're in the 2021 book, I know I rattle on and skip from one thing to another, but right here, HitPix came about because of the Balanced Budget Refinement Act. Any of these acts that Congress enacts for health care, be sure you know their names and their dates and what they cover. That's the one that covers for HitPix. I know there's one for Obamacare, and then there's one for when Clinton was in office. There's another one. There's 3 acts that we should know and get them written in. I'll make sure I have them for my 2022 notes, but that's important for HitPix. So in HitPix, your G codes are going to be for your Medicare patients who get an annual wellness exam. That annual wellness exam can only be used once in a lifetime, even though it's called annual. When a patient gets Medicare for the first time in their life, when they hit 65, they can have one or the other of this particular G code. So your test question will say a new member of Medicare. They will be saying something about a patient just registered for Medicare. They are new to Medicare. They're going to use some sort of verbiage to say that they need their annual wellness visit. This is a once-in-a-lifetime visit. They can't get it ever billed again after they've had it the one time. These are the 2 codes that they'll use. The other codes that they use for Medicare. Hey, baby. I heard the...
Which one do we use? Is it the 9?
Let me see, baby. Let me see. Either one. You can use the 5G or the other one, and you know the code is written in that drawer, right?
Okay. I'll use 5G.
Yeah, either one. Okay. And then the password is written in the drawer.
Okay. Yes, ma'am.
Don't you dare drop that switch. Good gracious. Sorry, all the new company that's over wants to know where the password is to the internet and which internet one to use. I got 2 routers here, so I have to have internet. to work from home, so I've got two things going on. On page 192, if you're in the 2021 HitPix book that AAPC gives out, they've got 6 codes here they commonly use on the exam. These are for the screening pap smears for Medicare patients. So be sure you know those and the differences of those. The next page before it, the 191, we've got our colorectal screenings. These aren't too bad to know because this one's a flex sig. This one's a barium enema. This is a colonoscopy for a patient who does not meet the criteria for high risk. This one across from it is high risk patient. And this one is a screening. This one only goes to this one's a flexible sig. It doesn't go all the way through the cecum. This one's the one that goes all the way through. We've got another random pap smear over here. That's the one that's most commonly used on page 190. Yep. And that's it. Those are going to be the ones that are on there. We've got trimming of the nails for your diabetic patients that are on Medicare. That's up there in that top corner. But your test question will definitely say the word Medicare. When you see that, you know exactly it's going to the G code. And if they only have one answer with a G code, you can just pick it and move on. You don't even need to look it up. But if they have a couple of them, just be sure you note. It's probably be the difference between a flex sig, a barium enema, and the regular colonoscopy. So you just need to note the differences in those because that's a barium enema, that's a flex sig. They don't go all the way through the colon. So that's the difference. They stop ahead of time. How often do you code from the HitPix? You'll have 5 codes, 6 codes, 5 or 6 codes from the HitPix section for the entire quiz. That's all. It's not many. You'll have your typical 2 Medicare ones, the colonoscopy and the pap smear, or the wellness exam one. And then the other 3 are going to be J codes for your injections. There may be a chemotherapy one for the medication in here that you'll use, but those are back here in the very back of the J codes. The common J codes are going to be your knee injections, the Depomedrol. You could use your albuterol treatment, the liquid solution that goes in the machine, penicillin, normal saline, B12 injection, testosterone, or your estrogen could be common. They're not hard to find or tell the difference of. Some of them might be your birth control patch, your birth control implants, or your Depo-Provera injection for preventing pregnancy. Your penicillin injections are there. That's about it. It's not too bad. The chemotherapy one might get a little weird because the names are so hard to find because they have a med proper name, and then they have Dex. That's a steroid. That's a super good one. This one, you might have to multiply times 50 to get your 50 milligrams, 0.50 milligrams. So don't be afraid if it's times 25, because that's a small dose. Some of the chemotherapy ones are hard to find because their their structure name could be super long or hard to discern compared to their proprietary name, and sometimes you don't have both, or they're not clear. You've got the name, but then you've got like a name brand name. Sometimes they're difficult to find in the 2 minutes that you need. And some of them aren't in there at all, and you just use the J99999 code because it's not listed. But it's very hard to discern whether it's really listed or not, because some of them have 2 manufactured names along with their other name. It's one question. They're all weighted the same out of 150. If you're spending too much time looking for the right name, don't worry about it. Do your best guess by process of elimination, picking out 2 codes that look the same. They're super close. They're going to give you something that's going to be named the same. Like these 2, I don't know if you could tell, the J9355 and the J9356, same dang name. The TRASTUZUMAB, they're both 10 milligrams too. It could be really challenging trying to figure out which one is which, and the only way you can tell is if you go to this publication and go to the chapter and look at how they reference it. These publications will give you the difference between that and that. You could spend a lifetime getting the information to the codes that you need. Just like the ICD10 and CPT book have publications, so does the HCPCS book. So if you notice at the bottom of a lot of these codes, they say another book. Well, that's what this is. And they do one every year. And these can be really expensive if you want to get current year ones. But they go through that code. They'll give you rationale for using that code. They'll tell you why people are using it wrong. And then they'll also give you clinical examples on how to use it. And they'll give you a further in-depth, you know how this CPT book gives you that description. It's 5 words or less. Well, they'll give you a full description on the exact code. And it goes on for days and days and days. And then they'll give you more clinical examples of it and how to use it and how you should be using it. These are great books, but it's yearly, and you'd have to buy every one of them, and then you'd have to go through each code and write a summarization of all that information. And I'm working on that, on the codes that I know appear on the CPC exam. I'm working on getting all those books because they reference not just 1 year, they reference multiple years, but also HCPCS has the same thing. I really should get one that does a lot with the chemotherapy and try to find that information on some of these and separate these out a little better. Like these coding clinic ones from 2011, they're going to give some better examples of when to code these, especially when the names are the same for several of these drugs. I mean, it's the same, sulfate, sulfate, sulfate. It's, and then one of them's a titrate. Now that makes sense, but sometimes your test question won't tell you if it's a titrate or a sulfate, and you're supposed to guess off of what? I don't know, but it's supposed to be, the coding clinic will tell you which one. So it's just one question. So if you prep your book and know as much as you can off the ones that I've told you are always going to be on the CPC exam, and you've written at least 2 clinical examples per page of CPT codes. You've got everything boxed. You've got everything highlighted after your semicolon in your core code, and then everything on your child code. You've written in or done your distinguishing between the codes, like open is circled, closed is also circled, but I've got different colors. Green is for open, orange is for closed procedure, because those are the same procedures. Everything's the same body part and stuff, but one of them will be open procedure, one of them will be closed. If you've gone through, written some headers, what body part you're working on in this particular section to keep you straight during the exam. You've made notes on which to not use together, because they tell you what code you can't use together. The CPC exam is notorious for going on and adding an answer that will be right here. You can't use the 55 code with a modifier 50. Oh, this one's telling you to report a bilateral procedure to use the modifier 50, but they also will tell you when not to use codes together. If you highlight the parenthetical notes that tell you when to use a modifier or tell you when not to use this particular code, and you actually check those before you answer the question, then you'll be more likely to get a passing grade. Missing at one chemotherapy injection is not going to be the end of the world if you've got the core of the course or the exam done, which means adding to your anatomy for sure, all the prefixes, suffixes, when to use modifiers, when not to use modifiers. Your most intense procedures, because that can be super helpful in deciding which code to use and which are the least. What's up? I know, we already discussed it, baby. He knows to get it, but yes, I will remind him. Why? He couldn't go? Why couldn't he go? They didn't want to hear 50 questions during the entire ride? My oldest just left and left one of the youngest ones here. He wanted to go to Vegas with him and pick up the other person, but he was not invited, so he's super sad. If you've gone through the entire book and done your boxing, your highlighting, added in information, single, dual, one lead, two lead, unilateral, bilateral, these are all keywords you could use. Marked your do nots, marked your when to use. You've done 2 examples at the bottom of every one of these pages. You're going to be in a really good spot. You need to learn the differences in your cabbages, your moss. You need to learn your guidelines for burns, for underdosing, overdosing, for injuries, for your ulcers, gauging the wound ulcers. There's 4 stages. You need to know your guidelines for... What's else? What else, guys? What else? Grab that book. You don't really need to know the heart failure too good, because it already comes in order for you. Your sepsis guidelines would be helpful. I have a 1-sheeter guideline, one made up for that one. I love this little box that AMA put in for your chemotherapy. You need to know the differences between your guidelines for coding chemotherapy and radiation and immunotherapy. Sometimes they're split. Radiation will be coded a different way than chemotherapy and immunotherapy. Sometimes they're the same guideline, like for anemia, but for dehydration, they'll code those things separately and in different order. So be sure you know the differences between those. And even if it's just dehydration and nausea and vomiting for no reason, even if it's not a chemotherapy issue, be sure you know that guideline. They love to pick on those. Long-term use of meds, your radiation chemotherapy treatment. your burns, your injury, the external causes for sure. Check my messages. How often do you code? Okay, I did that one. And are any of the APC practice exams ever the actual test? Let me show you an example. YM Spencer, I hope you're still here because I got you on this question. I know for a fact that the questions, sorry, I'm trying to find my mouse. What did I do with it? Where's the mouse? There it is. The AAPC is still selling the same practice exams, A, B, and C, that they had back in 2019. I haven't updated them yet. Let me see. And this is their practice exam right here. This is practice exam A. So their practice exam right here question says, what is PHI? And then they give you a list and you pick your answer. Pretty bare basic, right? But the question on the AAPC exam for certification will list out several things and say which one is not PHI. It's totally different, written totally different, and it's not as easy. So it will be written in reverse with a different concept. It does help to go over these, but it's not worth $400 for sure. And they're tougher. They're tougher on the exam than they are right here. They make them way too plain Jane. I wish they would challenge you just as much here as they are on the exam. And you only have 2 minutes to figure out the answer. So, it could be challenging. This one would be a question where I don't read the question. I would run to 04 and I would run to 20 and see what the differences are in those two. Get a key word from each one of their descriptions that is the difference, and then search. It's going to be screening because some of these are going to be diagnostic, and then one of them is just going to be screening. So once I narrow it down, it's going to eliminate 2 answers. Then I got a 50-50 shot. You need to always read the answers before you read the question, and you're never going to read the question. You need to just do word searches for keywords in the descriptor for the correct answer. Anytime these word questions, anytime you see a word that says always, just eliminate that from as an answer. Anything that says always, for sure, get rid of it. Only, get rid of that too. Any definitive word that is like only, always, must be, those are exacts, and medical coding has got nothing to do with exacts for sure. Anything that says can be, hey, that might be an answer. That might be an answer right there. So, and the funny thing about this is, because we know OB does take priority over other codes in chapter, the next 2 paragraphs right after they tell you that in these lovely guidelines, if you're in the OB section, will then tell you, oh, except for this, that, and the other thing. So if a patient comes into like the OR and they're having, they just, sliced off the tip of their finger while they were shredding something up in the kitchen, and they go to the OB, they're pregnant. You don't code pregnancy first. You're going to code the injury to their finger because it had absolutely nothing to do with the OB. And it didn't hurt the baby. It's not, they could be 19 weeks pregnancy, the pregnancy's going fine, but they sliced off the top of their finger and they need to get it reattached or get some stitches. You will obviously put down that they are pregnant, but it's not going to be your primary code. So it doesn't always work that way. So But as a hint for these worded questions, anytime you see only or always, don't even read it. Don't even read whatever's being said in that sentence. If you see something that says can be, then great. But we all know the answer to that one is B. This is one of the ones where you need to know your sequencing, and you need to know the sections in your ICD-10 book, a general idea of what's in A section. That's your viruses and your need for antibiotics. What's in B, what's in C, what's in D. You know, just a general idea. I don't like people memorizing anything for this test. You need to prep your book so that you have everything you need in the book. Have it be your brain. We're not in elementary school anymore. We're all grown adults, and we don't need to memorize anything or recite anything. Use your material. But this one would be an important one for it. This one's having a slow heartbeat. No, Brady girls are fast, right? Brady girls are fast, and I don't know. I don't forget what the thing is, but this one's got some heart issues due to a medication. Do we code the injection first, or do we code the heart condition first? That's a very good idea on what kind of question you might get. And that's where underdosing and overdosing your guideline will come in handy, because that will quickly eliminate two answers right away, and then you know it's going to be one or the other, and then you only need to look up the difference between that 1 and that 3 to know if you're in the right medicine area. So questions are kind of helpful, but they're going to be much more involved than just that. Also, the reason for the question is usually hidden in amongst a lot of crap you don't need to read. Like I said, you don't need to read these questions. You need to be able to look at these right here and be able to pick out two that are going to be most likely the right answer. So we know we have an R something, and then we've got a cancer. Then we got cancer, we got, nausea, vomiting, something in that R section, and then we've got long-term use or a cancer something or another in the Z section. So just knowing what sections are going to be, you're going to know what's feasible and what's not. I like A and C because they're super close. The only difference is the Z code. You should always look at what they're really asking for, because they can trick you. If you don't actually pay attention, you can assume a lot by the time you get there, and you skip the last sentence because you assume what they're asking for. They did a lot of crap up here. You don't need to know none of their history. None of that crap. The only thing you need to know is what they did right there in the procedure. What's going on today? Which she will underdo today. Okay? She's fixing to go through a procedure, right? All this stuff is just there to confuse you, for sure. All you need to know is her diagnosis is for that day because of what they're going to be doing. Cells that led to the diagnosis of that blah, blah, blah. That's it. She just has that diagnosis. And that's it. That's all. All this other stuff is to make you think that she's going to need a bunch of other stuff and more diagnoses than what she already has. She doesn't need anything else. What their question right here is about this muscle what they would have is the question would be listed with these muscles all listed very similarly together as A, B, C, or D. And then they'll say which one is the upper arm. It wouldn't be the fancy word and then a plain word what it is. It's going to definitely be a bunch of muscles listed there. And then up here in the question, there might be even two sentences describing the pain that radiated from one thing to another and where would that area be. They're very different in the way they structure their questions. These exams are just so bare basic that in this one, they're going to list those surgery techniques and plenty more surgery approaches and techniques. And then they're going to list a surgery and say which one of these techniques would you use for that surgery. This is very easy compared to what the question would be. Super different types of questions. Sort of questions where you need to think outside the box for something that's going to make you pause and go, huh? Inward, outer, and then we've got another inward. You can match two inwards, and it's probably going to be that. And then you just need to figure out if you're doing foot or eye, right? That's going to be the differences. You see how I matched up everything? Facial is different, and we've got outward here, so we've got two inwards. So then one of them will be feet and one of them will be eye, and that one is eye, obviously. But it's still a bare basic one that would be a little easy. You don't need to look up the first code here because it's the same for all of them. All you need to do is to look at the second one, and we've got a 71 and a 72 that are super close. I would run to those, see what the difference is first. Get that one key term, one of them's with or one of them's without, something like that, and then go on a word search just to see what the difference is. And this one has to deal with the dry eye syndrome. Yeah, super easy. That's how you pick out the test and get through each question within 90 seconds, which you need to do because you need to bank time for things that you need to go do research on and try to find the answer. But the test is super different. Yeah, so all those questions that are super long, don't read none of that, because if you read 100 questions with, this is a 56-year-old dude with all this history, and we've done this procedure and done that procedure, and now they're returning today for this other procedure, all that is put in there to give you brain fatigue so you can't finish the exam. And it's all put in there to make you confused, to think you need to code more than you should. You need to never read the scenario, ever. You need to go straight to the answers, find 2 or even 3 that match. CC I would get rid of because it doesn't start out the same. And then I would just go to this code and that code, see what the difference is in those, and then skim the answer from the bottom up to see which answer. And the answer for this one is going to be this one, because the only difference between a basic and a comprehensive is the ionized calcium, which the basic does order, but the comprehensive doesn't, because the comprehensive does a total calcium. And so the test for ionized calcium is that one right there. But I used to work labs, so I'm at an advantage with that, but still I could use the process of elimination with this because the 53 is consistent in 3 answers. You've got 7 here that you just get rid of. Or C, I'm sorry. Oh, I said 7, but you get rid of that one. Get rid of it because the 47 is different. And then you just need to look up those two codes to see the difference. Yeah, it can make you really nervous to do that. That's why you need to practice a lot with the process of elimination. And you will get confident at it. You will get as good as I am at it. I haven't been doing it that long. I didn't even start making TikToks on coding subject until April of this year. It's October. It's not like I even thought of the process of elimination till months later. Finding out, networking with people, seeing what y'all needed to get help for passing this exam wasn't a overnight thing for me. I've worked months gathering information from you guys to figure out the best policy and procedures for passing this exam. So it's not like I've done this for years. I'm not a coder. I did not like coding, but everybody's passing. So I'm getting passes with 86%, and they're feeling confident, but they've got to not read the questions. You've got to look at the codes, do a process of elimination, then you go to the codes that you like, and you look at the headers. Find out what your differences are. In cabbages, it's super, super easy. Cabbages are either venous or they're artery. So, if one code set is under artery and another code set is under venous, you have 4 options. 2 of them are arterial, 2 of them are venous, then you know you can eliminate 2 answers right away, and then you just look and see how many graphs did you do. 1 graph, 2 graph, 3 graph, because they're all the same. If we're under arterial, it's 1 graph, 2 graph, 3 graph. Find out how many, pick that right code, and move on. It should not take you more than 30 to 40 seconds to code a cabbage, even though it looks big and scary in the op note that you're trying to do. You only need to know 2 things. Am I going arterial, venous, or both, arterial and venous, because that's right here, arterial and venous. And then I need to know how many dang graphs am I doing. That's it. And those are the only key terms you need to realize and find in your little op note or your question. Super easy. I know it's, don't be frustrated. Please don't be frustrated. That coding course, let me tell you, I have. Because when I got started doing this and I noticed everybody was failing, I'm like, why are they failing? Why are they failing when they're paying $4,000 for a course and then they're paying all this money for everything? I've got their COC course. I've got their CIC course, I've got their CBP course, I've got their COC course, their AAPC course, there's my COBRA we've been working on. I even have their new one they just gave away, which is the CDEI course. I have that one too. And if you've ever... And I've also sat and I have my CPC. So I know how the course is and how they teach people a coding course. And then I know how to sit for an exam and pass the exam. 2 totally different things. I don't believe that the course teaches you anything you need to know to pass the exam. It's a lot of busy work to keep you occupied, to make you think that you're getting your money's worth. The only thing that I did find helpful from them was, where'd it go? In my books. I have books everywhere. Not there, not there. Oh, I'm getting stiff. Where's my book? Where's my book? Where's my book? Look at this artwork. That's my 10-year-old. He did such a good job. Gosh. That's a cover of a book. Sabrina the Witch. The only thing I found helpful for the CPC exam was their study guide. But it's still too wordy and unhelpful with a lot of their stuff. It needs to be condensed into a better resource. It too hasn't changed since 2019, so don't buy a new book. Please go find a $2 used book somewhere. But it's wordy. It's way wordy, but it does have a lot of information that they test on, and they do pick a lot of stuff out of here to query you about on the exam. It's just too wordy still, but it was helpful. Way more helpful than their online course is, because that's just full of repetitive anatomy that goes on and on and on forever. And then they tell you tiny methodical stuff, like what is a hospital, and then they go through each department of the hospital. It's just tedious. And then for coding the hospital, they barely tell you anything really, really good that's helpful for the actual real coding. I don't know if that makes sense, but really getting into the nitty-gritty and trying to code, they could do a lot better job with their course. And the more that I work with them and teach and be a guest educator for them, maybe I can help out and make their programs better in the long term if I can continue developing a relationship with them. But I do like their study guide. It's just a lot of information, but it's still too wordy. And it's a good start. I like it much better than I do their course, for sure. Any day of the week. Don't spend $3,000 for the course, but go on and get the study guide. You can even get previous years. Super. Yeah, get previous years. Don't buy a current year. It's just taking you so long and hard. I know. And it shouldn't. It really shouldn't. What you should do is box your core codes with the child codes. Fix your arrays, meaning, because I call this my BAD method. It's BAD. So you're going to box, like I have, box your parent and child codes. Then you're going to go through the entire book and fix all the codes that are out of sequence. This book is in numerical order, and there's nothing worse than getting down to sit for your CPC exam and you can't find codes because they're out of order. And they'll tell you to go look for a range to go find them. If they're on the same page, I just draw arrows where they are. But if they're on different pages, I put in the page numbers. And once I find the code, I draw a red line underneath it, because that helps me find it better than their hashtag, because they started out with the code as being red. Then I should be able to find it as a red code. Some of them don't even give you a coding range. They give you a chart you need to go find and look up, and they don't even tell you what page number that chart is on. It can be very frustrating to find even some of the simplest codes. And once they have rearranged all these codes, it messes with the correct numerical sequence of the other codes. If you get through this book and you go through your 8300s, thousands, whatever, and then you go to your 3100s and then your 80 codes, there are a lot of codes that are out of sequence in just those sequences that don't say they're out of sequence, but they're out of sequence because you have the out of sequences in front of them or mixed in the middle of them. And it can drive you insane to find even just the simplest codes in this lab and path section. You can get lost even when they're not out of sequence, but they're just pushed out of sequence because of the codes that are out of sequence in those areas. You've got the 8300s before the 8500s. You've got a lot of stuff that's just completely out of whack in that section. After you fix your array, you need to distinguish between the codes. Like I put X-ray, X-ray. This is a CT with a biopsy. Some of them are MRIs, some of them are CTAs, some of them are only dealing with the cervical, some of them are just thoracic. You need to distinguish your bundles to light up for you so that when you're picking codes, you've got your stuff there. Also move your guidelines to the certain codes that it affects, especially in your ICD10. Oh. But if you spend 40 hours to box all your CPT codes, fix your arrays, and distinguish between the codes, then add some more hours to add to the anatomy and prefixes, suffixes before every section, you'll be in a lot better shape to take the test than any course will give you. If you take those guidelines that I went over that are super important, like burns, you move the guideline to the actual codes, and endocrine erosion. Did I do it in this book or did I do it in the other one? Where is my burns? My burns. It's probably in my other one. Nope, there we go. You move the guidelines to the burns because you always sequence the third degree first, then the second degree, and then the first degree. You also, if you have multiple third degrees, you do the biggest burn area, surface area of that third degree section first. And if you have multiple second degree burns, you'll pick your biggest second degree to go first in that particular sequence, and then you move down to the first. If I have examples on another page, like 1115, for a particular guideline, you'll see here down at the bottom, I've got a burn patient, and I wrote out all their CPTs and diagnosis codes in correct order of how I did it. I wrote it in that blue color, and then I'll go to all the codes that were in that particular example and just write example and circle it so that I know I can go back here for during an exam. I have them all listed, even the external causes. I can go to X12 and it'll be back there saying that I've got an example on this page so that I can keep my sequencing straight, and I'll have an example during any exam to keep me going in the right direction. And if you move your guidelines from the front to the index to the actual codes listed, you've written it 3 times at least, you'll know it a whole lot better than if you didn't know it at all, or if you left it just up there in the front of the book. You should move all of the guidelines that I know are going to be on there to the actual codes affected. Look what I did for external causes. I not only wrote them all in the indexes, but I carried this throughout the book in multiple places. It's never diagnosed first. You always do the cause, the intent, the place, the activity, and the status. And if you even go to the index in the front of the book, where you've got an extra index for just in external causes, right here, I have it listed there too. And then everything that's intent, I have highlighted in blue. Anything that is pink, I can go back. That's the activity they were doing. And then I can go to status and highlight it there. It's more about not memorizing anything and prepping your book to hold all the information that you need. Status is green. That's the last thing you would code. And those are right there. Blue are the intent, suicide or not. I've highlighted them and colored them that way. And it's even in my book like this. Hold on, my kids. Yes. Oh, there he is. There's little man. How are you doing, sweetheart? Are you getting hungry? Oh, my cats are probably getting hungry. But this kind of stuff and writing in the examples of burns, how to do a few of your ulcers. This one, I've got, what is this, preterm labor. So I have an example on page 909. So I can go to 909 and I'll have written in a preterm labor scenario, how they diagnosed and coded it, and then to every one of those codes I went and wrote example on page whatever in the same color. So I keep my color straight and go back to the same ones, because you can get in that CKD same color. So I keep my color straight and go back to the same ones, because you can get in that CKD area where you have kidney disease and they're on dialysis. And you can have multiple examples on that same one page. So if you do a different color for each scenario, I wouldn't do no more than 4 of the CKDs, but you can find tons of examples of those that in whatever it is, N16 or N19, whatever it is. There's lots of kidney disease examples of test questions. But any time I had a test question, I wrote it down in the book and then moved the guidelines to those areas to help out. But the prep work to get these books ready will help you out way better than taking any course. I know my guidelines look crazy, but I'll go to those codes and actually write down the sequencing scenario at each section of all the guidelines. Just having it up here, I don't have time to go reference it here during an exam. I need it with the code, because your test questions are just going to have all the codes listed. That's all. So that's what I do. And I'm working on the 2022 guidelines now, and I'm not going to have it handwritten. I'm typing all of this. I'm about halfway done now. And I'm adding in screenshots of where in the book I wrote them, or in the CPT book, or in here, how I noted it, so that I've moved this guideline to the codes and showed you exactly also what does it mean. What the heck? I mean, there's so much stuff they don't teach you. Like, you see those yellow vertical lines right there? It means this. The vertical yellow lines appear in the second and fourth indentation throughout the index. Well, what does that mean, and why do we care? Well, it's tied to your guidelines. You need to know when you can and cannot bill certain things. You can't bill things that are not on the same yellow line together. Did you know that? There are certain things that no one teaches, and if you don't go through these guidelines and baby step it all the way through, figure out what they're meaning and what it's tied to, you'll never know. That yellow thing goes with this guideline right here. If the same condition is described as both acute and chronic, and it has a separate sub-entry exist on the alphabetical index at the same indentation level, code both, and you'll code acute first and chronic second. My example for that one is thyroiditis. Thyroiditis has the same code for acute and chronic that match up on the same yellow line. So if a patient comes in with a chronic disease process of thyroiditis, but they're having an acute flare-up, you can bill for the same disease on the same day for that. There's so much to this book and what they're trying to tell you for why they're doing certain things that no one teaches. There's another thing that I saw the other day when I was working with these codes that is new. Did you know they give you examples of how to diagnose things before the diagnosis section? There are notes, and it will be a box, and it's red before, and it's listed at a header, and it will say notes. And when it does that, it means that they're telling you in everything that's written below, here's some scenarios, here's how you would diagnose these, and they're giving you the answers right there in those particular notes, right there. For these neoplasms, they've given you some extra added information about the guidelines and how you would diagnose them in these note areas, which could be very helpful. And I don't think anybody teaches that either. So I'm trying to make sure that we have more information than anybody else, and we can pass these CPC exams with even 90%, easy peasy with my book prep and guideline prep, and without ever having to stress over anything again. We can just prep the books like they're supposed to be prepped and move on. Even the instructions on how to use these books, if you get past the guidelines, is it after this? No. Yep. How to use these books to get your credentials. This page tells you to go throughout the book and mark it. They want you to tab it. I think tabs just stay in the way because you're just looking up numbers. It's not like you can index anything during your credentialing exam. Some of the CCS people do code from a scenario, but not for CPC. But they want you to label them. They want you to move things. They want you to transfer your guidelines to the other parts of the book. They want you to do a lot of things to these books. And even the CPT book shows you and tells you in the front of it what to mark on every code as you're going through it to make notations and noting the differences. They tell you to go to everything and mark what's after that semicolon and highlight it. And then in the child code, they want you to go through and do that. If you're learning to use these books, they do have the instructions on how to use these books. Nobody pays attention to how to mark your book and how to prep it, even though they've got the instructions. Now, why they're telling us to mark it up when they're the ones with the ink and they could do it themselves, that would be nice, but they don't. They make you go through it and highlight and note it just like that. But I think they could do it themselves. So you're supposed to mark everything and highlight everything after the semicolon in the core code, and then highlight everything in the child code after they say the word bubble, but that's copyrighted. I can't say it, so I write box. Yeah, I do lots of lives, and I repeat my lives on YouTube if TikTok records them. Sometimes there's errors, and they don't record them 100%. I'm trying to bring you up something. Here's where everything is. On Medical Coding by Jen, on the front page of that website, if you scoochie down halfway down, I've got an E&M quiz right on the front page. You don't even have to join the page or anything. You could just take the E&M quiz. It's a hard one, just so you know. The test questions are from AAPC. They are my continuing education class course for keeping my CEUs for every year. So it's new stuff coming out for CPT coding for E&M. So some of them are tough. No one gets the second question right. But those are right there. I've got a 10-question free thing there. There's my TikTokies. I try to do 3 a week for 2 hours each, hour and a half. Messenger, we have a chat group, which I'm in right now, and this is information that I share daily. I have copies of every page of my CPT book listed here on Etsy, if by chance you wanted a copy and just print out and copy my notes, but I do teach you how to do it yourself. But I also have YouTube where I place all the old live videos there, and I've already got a stockpile of them, and I'm posting some TikToks there too, so that everything's all in one location. What if I wrote stuff that isn't allowed and I don't know it? What could you write? All you're doing is taking the stuff in this book and moving it where you need to. Like the ICD10 book, you're just taking those guidelines and moving them to the codes that it's affected. There's absolutely nothing here that I'm teaching or saying that you cannot write in your own book. The anatomy, they won't let us bring in a medical dictionary anymore. We used to be able to. The CCS, AHIMA people are allowed to bring in a medical dictionary. We can't. So we got to know everything that a doctor knows on a procedure and how they perform it to take the CPC exam. Well, you need to add more anatomy to it. One good location for anatomy is actually your ICD-10 book. And if you look at every section right before you code it, there is a great little anatomy area in it for every little thing that you're fixing to do before you diagnose it. It has right here for your nervous system. It starts out on a cellular level. What is the nervous system? What organs or things make up the nervous system? And then it'll go into what disease processes can happen during that. AAPC picks this as questions. So I would recommend any new words, all these words, you write a definition and you move it to your CPT book, to your nervous section. So all you're doing is rearranging all the information that they've already given you in your 2 reference material books, these 2 books, and you're putting it here where you're going to be coding, because 90% of that test, CPC, is in the CPT book. Move your definitions over here or here. There's a list of all the modifiers for nervous system. I'm not putting anything in here that it should not go here at all. And as a coder, if you need to know how to code a particular code, you can write a small little scenario how to code it. This is a left eye neoplasm. They used a frontal scalp retracted. They did posteriorly. The forehead was done anteriorly. They coded this with that. Simple. I didn't write what is this or use one of the AAPC questions and write it in there. I just do 2 per page of something to code from those pages and write a scenario just like any other coder would be doing. And a lot of those scenarios can come straight from their study guide. Their study guide gives you lots of little tips and hips and examples of coding. Also, you can use these books that give you coding examples, clinical examples of how to code a particular CPT code. You don't need to write that they're 60-something years old, blah, 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 but you can say that they need a PET to do this with imaging, and they used localization, blah, blah, blah. for cardiac ischemia and that code. Just pick out 5 or 6 words from that scenario and write it next to that code. Perfect example of what you can use, because this is straight from, and it says Coding Insider right here in these books where they give you examples. That word, the insider view, is on 90% of all these codes. So you can use what's in these books, just moving it around and putting it with the codes. You can either get a copy of my notes, which I have it in the front of each one of my chapters. You can read the parenthetical notes at the end of each one of the codes, because they'll tell you when to use a modifier and when not in some cases. And you can add that to a list in the front of your book to let you know, okay, I saw a code in here. It said I could use the bilateral code. So you'll put the 50 or 51 there. There are certain codes you won't be using during certain areas. You either find out from other people or you find out in your directions right before your coding section. They'll give you modifier tips here too. Like if we go to, where's musculoskeletal? I like that one. It's a good example. I think it's in the section right here. All these notes, they give you all these pictures, and then they give you all these words. Well, right here at the very bottom in musculoskeletal, it says to do a reduction of any bone where they reduce the fracture. They take an x-ray and then they decide they need to reduce the bone fracture. It says to use modifier, which one is it? 76 in that section. So if you just read what's in the book, then I knew I could add 76 is one of my common modifiers in this section for reducing fractures. And I wrote it in the very front of the book. And you can also write it at the header of some of the pages up here too when they're doing reduction of bones. When you're in the femur, because we're in the spine, you wouldn't reduce a spine, but maybe shoulder. It's mostly in the forearms and wrists. You could do the reduction note right there, all you wanted, for sure. It's just gathering up all the info and putting it where you need it. Let's see. How do you get to that site? So Etsy, I'm under Medical Coding by Jen. On Messenger, our little chat group where we talk every day and share information, there's my new coding grid by MDM and Time. Sorry, my cat is hungry. I've got to go feed him. But we talk and share info all day long. So you just need to find me on Messenger, on chat, which is there. That's me. Same profile pic. And message me, say you want to join the group. If there's space, I will add you. Sometimes it tells me there's not enough room, that I can't, because I've got almost 80 people in there. But people come and go as they please. I can add you there. My notes are on Etsy. Even if you get one section, my best section is medicine, because it was the last one that I did. And like I said, I was figuring out how to do this along the way, starting in April, and that was the last section I went through. And I've got all my little tricks and tips and even added examples on pages in that section. And then you can transfer what I've done to all the other sections in your book if you want my suggestion, if you just want to get one section. But I do the TikToks, I repost everything on YouTube, I have the website where you can schedule one-on-one with me in the books. It's like $27 for 40 minutes with me in my books, and we can go over stuff that you want to do one-on-one, just like this with the camera, and right before your exam to make sure you're covered all your bases. I don't need to see you. You can just watch what I've got going on here on the computer. And then Messenger, I've got the free chat group we got going on, and that's it. That's where to find me. Let me check my messages here. Is the E&M grid for Yes, it's for both years, Cassie, both years. Hey, Danielle. Yep, my little grid is for both years, for sure. I may add to it for next year. You know how the E&M got rid of some of the descriptive words for some of the established and new patients for the history and the examination. I may add those to another grid, but really all you need for the CPC exam is MDM and time. That's all you need. It's all they're matching with nowadays, so that's why I made the grid that way. But some people miss the other way of doing it. But since it is 9 o'clock and I've been on here, 6:30, 7:30, 8:30, no, really 2.5 hours? Oh my gosh, no wonder I'm tired. I am going to go and go visit with family and check out everybody. Ooh, somebody went to the medical coding by Jen site. Hopefully you can take that E&M test and see how you do. It's tough. It is. It's weird. You got to pay attention to what they're asking because there's information in there that they're not asking and it's going to confuse you. So anyway, good luck on that one, and I hope this has been helpful. If you've enjoyed it, please be sure and like it and share it and do all that stuff so we can reach more people. And my cat is staring at me still. Like, woman, come on, it's dinner time. Anyway, I hope y'all have enjoyed, and please leave me messages on TikTok or my link in bio. If you click off on my face after this live, it will link you to my email address, and you can email me too if you have questions you want to take on the side. Thanks, Spencer. I hope that's been helpful. I'll see y'all later.